Last but not least, but certainly the shortest, so I apologize for that. Hopefully you can see me okay. I'm so honored to be here today, so thank you very much to the Purina Institute for inviting me. I am going to talk to you about the impact of nutrition on allergy and tolerance in dogs. Hopefully, as you heard my bio, you know that I'm not a dermatologist, but I will be talking a bit about atopic dermatitis, and hopefully you'll understand why in just a bit. We know that in terms of the immune response, we've learned a lot over the last 2 days how the immune responds and maybe over-responds or under-responds, and that leads to disease. So we heard from Domenico about this sort of type 1 hypersensitivity reaction leading to immediate urticaria, angioedema, pruritus, and then atopic dermatitis being sort of in the middle where we see both IgE-mediated and cell-mediated immune responses. And then what I deal with as a gastroenterologist is these chronic inflammatory enteropathies that we think of more of a cell-mediated response. But the reason why I'm here to talk to you about the skin is because really Hippocrates in 340 BC was absolutely correct. My impression is that all disease, I don't care if it's Addison's or kidney, it begins in the gut. And the reason for that, again, that's a little bit of an overstatement, but we do understand, we've heard about the idea of a leaky gut, a leaky epithelial barrier, a leaky epidermal barrier. All of those things contributes to the development of disease, whether it's in the gut, whether it's in the kidney, whether it's in the skin, whether it's in the lungs. And so what we have here is that we have this defective epithelial barrier starting here. And then as a result of that gut barrier dysfunction or the epidermal barrier dysfunction, you have these damaging agents. Maybe that's food allergen, maybe it's pathogens. And then the immune response is, okay, this is not self, this is inappropriate, I'm gonna ramp it up, and I have an immune response inflammation. That may then lead to something like colonization of these opportunistic pathogens, maybe a dysbiosis, you get decreased bacterial diversity, you get, again, more translocation of maybe microbiota or food allergens. That, again, causes this inflammatory response. That then leads to barrier dysfunction, and as you can see, there is this vicious cycle that continues to occur. The good news for us that are really here to talk about nutrition is that, yes, indeed, nutritional intervention can restore barrier function. And I've listed a few papers, and those are in my proceedings as well, that would show that with early life treatment, or maybe as Stefan was saying, you have a dog that presents to you with parvovirus, or a dog that presents to you with acute hemorrhagic diarrhea syndrome, we oftentimes, as nutritionists, as gastroenterologists, we say what? We say, change the diet for 3 to 5 days, transition back to the normal diet. Is that the appropriate thing? We have these studies. For example, we heard about colostrum yesterday. We heard about colostrum in terms of how it modulates inflammation, how it modulates the immune response. And there was a study that was performed in these puppies, these weanling puppies, and what they found is that the puppies that were exposed to this early maternal separation stress, when they received something like colostrum, actually had less inflammation in their gut. They had more of an appropriate immune response. And so can we figure out, actually, can we address nutritional intervention earlier and have a better response? Because we understand that this targeted nutritional approach can be very successful when it's instituted before the disease becomes well established. The problem is this. The patients that I see on a referral basis look like this patient here. So poor body condition, a belly full of fluid, poor muscle condition. This is a histopathologic sample from a patient who had intestinal biopsies. And what we can see is that there's villus atrophy, there's mucosal sloughing, there's an exuberant inflammatory response. So the problem is that by the time they come to us, we're reactive, not proactive. The disease is well established. And so what we need to do as a community of clinician scientists is actually do a better job of understanding who is at risk. And there are many models for that, right? We recognize that there are certain diseases. There was a question from the audience about the effect of genetics. And I think we all know golden retriever, top differential cancer. I don't care what the age is. German Shepherd, top differential will be diarrhea at any point of life at any time, right? So we know that there are these breeds that we feel like, yes, environment does play a role, but certainly genetics plays a big role too. Soft-coated wheaten terriers are no exception. We know that these dogs oftentimes present with protein-losing enteropathy somewhere around young to middle age. We suspect that intestinal inflammation, intestinal lymphangiectasia play a role. The problem is, just like that picture that I showed you, these dogs usually come in, and by the time they come in, the disease is so well established. Our therapies, whether it's nutrition or pharmacologic, oftentimes we struggle to get these dogs back into remission, and so generally speaking, they're euthanized shortly at the time of presentation or shortly after we diagnose them. There's also evidence to suggest, because of the timing of when these dogs develop disease, so they get gut disease first and then they develop kidney disease. And so some suggestion is that maybe their gut disease, they form antigen-antibody complexes that then leads to kidney disease. So if we could recognize this gut barrier dysfunction that happens earlier and intervene earlier, would we have the ability to improve health span and lifespan in these dogs? And Karin's group has looked at this in the soft-coated wheaten terrier specifically. She took a population of healthy soft-coated wheaten terriers and looked for peripheral anti-neutrophilic cytoplasmic autoantibodies in the serum of these dogs, and that's a marker of inflammation. And she found that 20% of healthy soft-coated wheaten terriers had detectable circulating peripheral anti-neutrophilic cytoplasmic antibodies. And then in a subsequent study, she looked at dogs that had PLA and PLN and found that this biomarker was increased in serum on average about 2.4 years before dogs developed hypoalbuminemia. So we wanted to take this work a step further and look at soft-coated wheaten terriers that owners think of as healthy and determine, even if the owners think they're healthy, is there already evidence of disease? And so we did things like video capsule endoscopy, we did fecal markers of fatty acid sterols, we looked at bile acids, we looked at dysbiosis index, we looked at calprotectin, and our overarching hypothesis was that these healthy soft-coated wheaten terriers who don't have any clinical signs of disease to their owners are gonna be diseased, one way or another. So in our groups, we took healthy non-soft-coated wheaten terriers, healthy soft-coated wheaten terriers, that was kind of our at-risk breed, and then dogs of any breed with protein-losing enteropathy. It's a 40-minute talk, and I have to talk about nutrition, so I'm not going to tell you all the things that we did today, but we did a variety of different things in this study. I'm going to start with the intestinal permeability data. So on the y-axis, what you can see is blood lactulose to galactose. Stefan talked about iohexol, kind of a similar idea, right? So lactulose is a very large, non-absorbable polysaccharide that shouldn't show up in your blood if you have an intact intestinal epithelium. And indeed, what we can see in these healthy dogs that are in blue, that there's very little lactulose in their blood. The dogs with protein-losing enteropathy, as we would expect, have a lot more leaky guts, and so lactulose shows up in their blood. But hopefully you can see here, it's interesting to know that soft-coated wheaten terriers are sort of the stepping stone towards PLE. Again, these are healthy dogs, no GI signs, no pruritus, no vomiting, no inappetence, eating a standard maintenance diet, but yet they're already showing signs of disease. I'll also point out this outlier. Jessica Quimby was talking yesterday about paying attention to outliers. I didn't have this permeability data when the client sent me an email. This is an oncology resident from NC State. And she said, "You enrolled my dog about a year ago as a healthy dog, a healthy non-soft-coated wheaten terrier. It served as a control for your study. My dog is now vomiting, have periods of anorexia, hyporexia, and I'm wondering what's going on. What should we do? Should we do something about this dog?" And indeed, that was the dog that we saw as an outlier, which I find very, very interesting. When we looked at the video capsule endoscopy data, all of the dogs, interestingly, had some evidence of mild to moderate GI bleeding. But when we looked at lymphangiectasia, so we looked for evidence of dilation of their lacteals, such that they're losing rich fat, rich protein fluid into their intestine, as you would expect in these PLE cases, all of them are leaking, having this intestinal lymphangiectasia. It was a very uncommon, rare thing that we saw in the healthy non-soft-coated wheaten terrier dogs, but again, we can see here our soft-coated wheaten terriers, more of them are affected, a kind of stepping stone towards PLE. So then that prompted us to look at their fecal fatty acids and sterols. This is a principal component analysis of all of our groups. Here in blue is our PLE dogs. Red are healthy non-soft-coated wheaten terrier dogs. And green is the soft-coated wheaten terriers. And hopefully you can see, yes, of course, they all separate into their own little cohorts. But again, like we saw with all the rest of the data, the soft-coated wheaten terriers are not normal. Something is going on with that breed before they develop clinical signs of disease. We looked at calprotectin, a marker of intestinal inflammation, and again, what we saw was that not all dogs that had PLE and not all soft-coated wheaten terriers had increased calprotectin, but they were the only ones that did. We looked at dysbiosis index, and again, we saw that 4 soft-coated wheaten terrier dogs and 5 dogs with PLE had dysbiosis. I want to point out that this was not the same dogs that had calprotectin. So I know that dysbiosis in the microbiome is super sexy. This is like the hot kid in the neighborhood right now. But it's really important that we recognize that this disease is multifactorial. Stefan mentioned the importance of the mucus layer, for example. We know that thinning of the mucus layer, bile acid dysmetabolism, dysbiosis, malnutrition, all of these things can cause disease in these dogs. There's not one thing that we can say, yep, that's it. That's the smoking bullet there. That's the smoking gun. It just doesn't work that way, unfortunately. What we can say from that study is that dogs can have leaky barriers, leaky guts, long before clinical signs are apparent. And so what we need to be working on, what hopefully Purina Institute wants to get to work on, is to develop tools to recognize and treat these dogs earlier. To understand then what is the effect of diet, as Stefan said. If you give early enteral nutrition, if you give parenteral nutrition, if you give a hydrolyzed diet, if you give an elemental diet to these dogs that have acute insults or these breeds that are at risk, do you then decrease the prevalence of disease in these guys? The problem is that the disease, as I've just mentioned, is not uniform. So there could be numerous etiologies, as we've discussed: genetics, immune dysfunction, early life infection, maybe like we talked about, xenobiotics such as antibiotics for the treatment of parvovirus, malnutrition. We haven't had any time to talk about the effect of stress. Jody obviously talked about that a lot with FIC. That is a very underexplored field in chronic inflammatory enteropathy for sure. Environmental triggers and tight junction dysfunction. And then, to make this even more complicated, there's numerous sequelae. They can have an inflammatory response. They can have oxidant stress. They can have that decreased intestinal mucus layer. They have increased transepidermal water loss, abnormal ceramide expression in the case of atopic dermatitis, dysmotility, dysbiosis. And so, unfortunately, it would be nice to say, yes, you just use this bag of dog food and everything gets better. But we know that that's actually not right. We have to think, as nutritionists, we all know that actually it's about targeted nutrition. It's about taking the patient that's in front of us and deciding, what does my patient need? These are histologic sort of reports from 4 different dogs that had, in the end, food-responsive disease. One of them had chronic, moderate neutrophilic and lymphocytic plasmacytic inflammation, and the fish was negative. One of them had eosinophilic gastroenteritis. One of them actually had neutrophilic duodenitis with crypt abscesses. One of them didn't have any inflammation, at least at all, that we could see from the biopsies that we collected. And in the end, what I did, it was sort of like throwing darts at a dartboard, because we don't know, like, should I be giving more antioxidant therapy to the patient with neutrophilic inflammation and crypt abscesses? Should I be giving more omega-3 fatty acids, DHA, EPA, for that patient that has lymphocytic plasmacytic inflammation? We don't know. What we do is that we try to make recommendations that appear to be individualized for our patient, and we recognize that multiple factors are at play, and so we have to use a multimodal approach. A one-size-fits-all approach is not going to work, because I've only listed a few of the factors that could go into the development of disease, but there are many more that I mentioned. And so there are many nutrients, in fact. There are many functional foods that could be used to treat these dogs. The problem is we just need more studies, especially in the chronic inflammatory enteropathy space, to understand how to do this, how to take a few nutrients at a time and sort of throw it and hit a bullseye. At the moment, my darts are pretty much all over the place when I'm treating a lot of my patients. I do want to take some time to talk about some of the nutrients and ingredients that we know have been helpful in atopic dermatitis specifically, as well as chronic inflammatory enteropathy. So the big one would be obviously linoleic acid. We know that linoleic acid is really important for the creation, the production of ceramides, which maintain the epidermal water content of the skin. They provide barrier function. When you have a linoleic acid deficiency, you get dehydrated skin, you lose that barrier function. Linoleic acid can also activate PPAR alpha, which is really important for a number of things, including lipid metabolism. Linoleic acid has a best friend, and that best friend is called zinc. So zinc not only does its own things, right? We heard yesterday about the important role that zinc plays in a variety of different ways throughout the body. It does enhance intestinal barrier function. It's really important for fatty acid conversion, including linoleic acid, and it helps in the formation of the stratum corneum. So these are often used together. There was one study, however, that looked at the effect of zinc methionine in the treatment of dogs with mild atopic dermatitis, and this double-blind study did actually show a benefit of zinc methionine on its own for the treatment of that disease in particular. There are some earlier studies that looked at linoleic acid and zinc together. So in this particular study, they took 8 healthy Labradors. You can see the nutrient composition of the diet, of the test diet here as compared to what the dogs were fed baseline. So they fed baseline diet for 12 weeks, and then they transitioned them over to this test diet that was enriched with linoleic acid and zinc. And then they took these transepidermal water measurements at weeks 0, 8, and 12 weeks, which you can see here on the y-axis is that transepidermal water loss. So you want that number to be low. And on the x-axis is time in weeks. And so what they found is that over time, when dogs were fed this diet that was enriched with linoleic acid and zinc, they lost less water in their epidermis and presumably had a better epidermal barrier function than when they weren't fed this supplemented diet. EPA and DHA, omega-3 fatty acids, also get a lot of attention for their role in immune-mediated diseases, including atopic dermatitis and chronic inflammatory enteropathy. There are many studies, I've only just listed a few here, there are many studies that demonstrate that EPA and DHA certainly have a beneficial effect in the treatment of atopic dermatitis, where they do reduce the severity of pruritus. They result in fewer inflammatory eicosanoids. We know that they can have an immunomodulatory sparing effect, so dogs that receive these ingredients or nutrients have less requirement for things like cyclosporin and steroids. There's really less information, unfortunately and surprisingly. There are a couple of studies, I'll just highlight one here in terms of canine inflammatory enteropathy, where the investigators fed a diet that was enriched with EPA and DHA to dogs that had both food-responsive disease as well as dogs that had steroid-responsive disease. And they looked at their canine intestinal bowel disease activity index, which is just a measure of disease severity. So higher numbers with that scoring system mean worsened disease. And what they found in both groups, when dogs received this EPA and DHA supplement, there was a marked improvement, a significant improvement in their SEBDAY scores, suggesting that did have a benefit. And I think this is a space that we'll continue to learn more and more about. I showed you the fatty acid and sterol loss that we saw in our dogs with chronic enteropathy, or excuse me, protein-losing enteropathy in our soft-coated wheaten terriers. We know that disturbances of lipid metabolism are very common in dogs with chronic enteropathy and actually cats with chronic enteropathy. And so I think this is a space where we're going to continue to learn about how do we need to modify or modulate these lipids to help our patients. Medium-chain fatty acids are often talked about, especially in the chronic inflammatory, protein-losing enteropathy, lymphangiectasia space. People talk about their benefits in terms of, yep, they require less energy for absorption, they result in less intestinal metabolic stress. Some of them, but not all of them, are transported via the portal circulation, so the smaller medium-chain fatty acids like C8 and C10, some of those will be transported by the portal circulation, helping those dogs that have significant lymphedema, lymphangiectasia, if they can have some of those transported by vessels other than lymphatics. And they have been supposed to have positive effects on the gut microbiome, gut permeability, secretory IgA production. There was a study that looked at the effects of a home-cooked diet that was enriched with virgin coconut oil, and then they looked at dysbiosis index. So the kind of below that dotted line would be what we consider to be normal. Above that dotted line, we'd say that's dysbiotic. And so what you can see is that there wasn't really a marked effect of adding virgin coconut oil to the home-cooked diet and improvement of these dogs' dysbiosis. However, when we look at the canine chronic enteropathy clinical activity index, again, another marker of disease severity, we see, well, the dog started off with very mild disease. There was an improvement. However, it was difficult to determine from this study design, was that an effect of the home-cooked diet Was it an effect of the virgin coconut oil plus the home-cooked diet? Was it the virgin coconut oil? Or were these dogs going to have just sort of an improvement over time? Because we know that the dogs can obviously experience periods of remission and relapse sometimes without any interventions. I'm glad that vitamins were talked about and the role of vitamins, the importance of vitamins in these immune-mediated diseases, because I have one slide to talk about it in the interest of time, unfortunately, even though we could spend these 2 days actually talking about the role of vitamins in the development of immune-mediated disorders. B vitamins, we know that they contribute to the integrity of the stratum corneum, and anyone who took nutrition boards probably still has it in their head about where B1, B3, B5 plays roles in intermediate metabolism. It's sort of just ingrained in our head. We know that B6, for example, is really important for protein metabolism. In the chronic inflammatory enteropathy space, we only look at B9 and B12, so folate and cobalamin. We are missing the picture completely. We are missing some B vitamins that are probably really important for resolution of disease in these animals. Fat-soluble vitamins obviously reduce plasma carotenoid, the active form of vitamin A, retinoid, vitamin D, and vitamin E concentrations. They have been shown to be reduced in humans with atopic dermatitis as well as inflammatory bowel disease. And we know that hypovitaminosis D specifically is a poor prognostic indicator in dogs with protein-losing enteropathy. And in dogs with atopic dermatitis, we know that if they have hypovitaminosis D, they may have a suboptimal response to steroid therapy. And so we need more studies to determine when should we be measuring vitamin D? When should we be intervening with vitamin D? What form of vitamin D should we intervene with? We still don't have the answers to those questions, but it's certainly something that needs to continue to be investigated. Vitamin E, lower plasma vitamin E, and it has been shown in dogs with atopic dermatitis compared to healthy dogs. And these investigators did show that vitamin E supplementation was associated with a clinical improvement. And so potentially there may be some vitamins that we need to think about in terms of testing and supplementing. We learned yesterday about the idea that it's sort of not as easy as we might think it is. We want to hit the optimal ratio, right? We recognize low is bad, but excess is bad. So I'm certainly not recommending supplementation with fat-soluble vitamins without measuring to look for deficiencies, but it's something that may be important. Those dogs that you think should have a clinical improvement, you don't see an improvement. Should we be testing things like vitamin D and vitamin E and determining if we should be supplementing with those? I'm glad that Simon talked about the role of fruits and vegetables and potentially an improvement in immune-mediated disorders. One of the ways that they do this, other than fibers, is actually polyphenols. So polyphenols are organic compounds, again, that are abundant in fruit and vegetables. They can be found in green tea, ginger, licorice. You can see some examples here, some of the ones that we all kind of know and talk about a lot, whether or not we should just throw them into a supplement that we're giving this dog that has terrible chronic inflammatory enteropathy and we're throwing the kitchen sink at them. Why not curcumin? Okay, why not? Let's try it. Resveratrol, that's in red wine, the skins of red wine, which is why every night I feel really good about taking my glass of red wine to get my polyphenols, and then proanthocyanins. So these can do a number of different benefits, and there's many papers in my proceedings that I would encourage you to read because I found this a really fascinating topic. They can reduce insoluble complexes with antigens and therefore reduce allergenicity, and then they can actually activate NF-kappa B, which we recognize as the most significant arburator of the inflammatory response in the body, and also it's related to impairing epithelial function by tight junction disassembly. And so when you can inactivate NF-kappa B, you might be able to reduce the inflammatory cytokine environment, maintain tight junction function, stabilize mast cells. All of these things would be really, really helpful, at least in the chronic enteropathy space, as well as with atopic dermatitis. In addition to that, they can restore antioxidant systems via this nuclear erythroid-derived factor 2. I have to be honest with you, when I read this paper about polyphenols, I was like, what is nuclear erythroid-derived factor 2? So I'm not going to say I'm the expert on that, but that does help to restore redox homeostasis and increase antioxidant enzyme activity. And interestingly, polyphenolic compounds have also been shown to increase intestinal mucus secretion. So we talked about the intestinal mucus and thinning of the intestinal mucus being one of those ways that maybe you could start to lose barrier dysfunction because, as Stefan mentioned, we have sort of this inner layer, tight, adherent mucus layer, and then we have the loose mucus layer, and the bacteria, the sort of commensal bacteria are hanging out in that loose loose layer. Food allergens are hanging out in that loose layer. And so if you lose the mucus, then you're more likely to have translocation of some of those luminal microorganisms as well as those allergens. So polyphenolic compounds could increase mucus secretion and be beneficial in that way as well. There are a few studies, sadly, in the atopic dermatitis space rather than the chronic inflammatory enteropathy space that looked at the combination of polyphenolic compounds as well as antioxidants we can see here and polyunsaturated fatty acids. So this is not evaluating one particular ingredient. This is going to be a mixture of things, again, because we recognize there's not just one thing that you can give to these patients to help result in improvement. And you can see in this list that there actually is some crossover, right? So green tea is listed as a polyphenol, but it's also listed as an antioxidant. And in this study, this was an uncontrolled study. They took 17 dogs. This was out of the University of Tennessee with Dr. Angela Witzel-Rollins. And she took, she had 17 dogs that completed the study. There was more dogs that were enrolled in this study. This is the nutrient composition of the diet here. So you can see, again, there's more linoleic acid. There's more EPA and DHA. It's generally higher with vitamin A, E, C, beta-carotene. And again, it has those polyphenolic compounds that I described before. And she fed this diet to these dogs with atopic dermatitis. It was an open-label feeding trial, so just a sort of a pilot study. She fed it for 8 weeks. And then she did 2 measures of outcome. One was a veterinary assessment score, so you can see the results of that here. So here's the dermatologic site score that she used to assess for things like erythema, lignification, excoriations, alopecia. And she fed it for 8 weeks. So this is baseline, week 4 and week 8. And you can see that there was an improvement over time by feeding this diet. Now, Jody talked to us about the fact that you can have placebo-controlled effect. You can have a caregiver effect. Dogs may be getting better sort of treatment during the study. They think things are going better, or the veterinarian thinks that things are going better. So that's possible, and I'll show you a different study that does it a little bit differently. In this study, they did show that owner-reported outcomes were also significantly better. And so on this, we see, again, severity of the skin condition. Higher numbers is worse, lower numbers is better. They looked at pruritus, licking, ear scratching, and erythema. This is baseline, 4 weeks, and 8 weeks for each of these charts. And so what you can see is that there was an improvement by both the veterinary assessment that I showed previously, as well as the owner-reported assessment at both 4 and 8 weeks. Thankfully, because of the concern for a placebo effect, there was a follow-up study. So that was a nice pilot study to say, hey, is this something that's worth investigating? And it looked like, yeah, this is something that's worth investigating. So let's do another study and do it a bit more controlled. So in this one, this is a randomized, double-blind, placebo-controlled clinical trial where they evaluated that diet that I just mentioned with the polyphenolic compounds enriched in PUFAs, enriched in those fat-soluble vitamins, vitamin C, beta-carotene. And they compared it to dogs that got the control diet. They had 20 dogs with atopic dermatitis in both groups. And then they looked at the canine atopic dermatitis extent severity index over time. Higher scores were worse. So if you saw a negative number, that's an improvement. And to Jody's point, yep, the dogs that were fed the control diet did have a significant improvement. So there was a placebo effect, of course, but the dogs that were fed the test diet had a more significant improvement over time. These are the veterinary scores. Then when they looked at the owner-reported pruritus scores, again, we can see, yep, there was an improvement with that test diet. Owners that were feeding this diet thought, yep, things are going great. Thankfully, it was double-blind, placebo-controlled, and so they saw that there was a more marked improvement in the dogs that were fed the test diet. I'm really impressed by atopic dermatitis research because it seems like they repeat studies with a very similar thing, which is awesome because I feel like we don't have that in the chronic inflammatory enteropathy space. We have one study, everyone's like, yep, that worked, and let's move on. But they did it again. This is a slightly different diet, but very similar concept. So a diet that was enriched with PUFAs, polyphenols, antioxidants. They called this the FLAME diet, which is kind of interesting, and the control diet, which is the ICE diet. And they had, again, 20 dogs with atopic dermatitis per group. Again, this is a double-blind, placebo-controlled, randomized study. They looked again at the canine atopic dermatitis extent severity index, higher scores, worse. And so what we can see is over time, when their veterinary assessment, there was a significant improvement with the test diet that was not observed with the control diet. And importantly, what they showed when they looked at medication scores is that the dogs, over time, in this 9-month study, who received the test diet were less likely to have to receive additional medications for atopic dermatitis as those dogs that were fed the control diet. There are not many studies, unfortunately, that have looked at the beneficial effects of polyphenolic compounds in dogs with chronic enteropathy, but I will show you this one. There are a few others that you can look at in my proceedings. This was an interesting one where they looked at grape seed proanthocyanins and their effect on dogs with mild chronic inflammatory enteropathy. And they thought, hey, maybe these polyphenols will help because these dogs have mild forms of disease, and so maybe if we start some of these things earlier, we'll see a benefit. I think it's interesting that they just looked at this grape seed extract because, again, usually we don't see a really marked benefit of a single ingredient, but it's nice to look at. So what they had here is CIB-day scores, so disease severity scores, again, higher numbers, worse disease. The red are healthy controls that just received a vehicle. So healthy controls are always going to look kind of boring. And then the yellow are dogs with mild chronic inflammatory enteropathy that received vehicle. And then the blue are dogs with mild chronic inflammatory enteropathy that received this grape seed extract. And we can see it took a while, but over time, by day 28, there was a significant improvement in the dog's clinical signs when they received this grape seed extract. And same thing for their fecal scores, so higher fecal scores in the system means more watery diarrhea. As we go along, we can see that the grape seed extract fed to the dogs with chronic inflammatory enteropathy made their feces look a bit more like the healthy controls. They looked at a number of different pro-inflammatory cytokines as well. I've only pictured 2 in the interest of time, including C-reactive protein as a measure of systemic inflammation, and diamine oxidase. Diamine oxidase is concentrated in the mucosal villi, and so when you have disruption of the mucosal villi, you have release of diamine oxidase, and you can detect that in the blood. So it's basically a marker of intestinal epithelial disruption. And what they saw in the dogs that had mild chronic enteropathy that received the grape seed extract is they had significantly reduced C-reactive protein as well as diamine oxidase as compared to the dogs that received vehicle. So certainly something to look at. However, fair warning, that obviously we need more research in this space as well. We know that in some of these polyphenolic compounds, when supplied at levels higher than that found in natural sources, can be harmful. Like green tea extract is a very good example of that. So the person using it or the company using it really has to know what they're doing to make sure that they test for safety as well as efficacy. And there is an issue with some of these polyphenolic compounds as well as carotenoids and some of the other nutrients and ingredients that I've talked about, in that they can have variable bioavailability, they can have limited tissue distribution, they can have severe first pass effect. In the gut space, we have to think about targeting of some of these nutrients. So if we wanted to go into the small intestine or the large intestine, what is the effect of the acidic pH of the stomach? What is the effect of just sitting there in the stomach for a long period of time? Does it degrade? And so there has to be some thought about what concentration do I want to use? How do I deliver it? Do I need something like a nanoparticle delivery system, something like a liposome, or a pH-soluble encapsulation so that the nutrient of interest is delivered at, let's say, a pH of 7, such that it actually gets to the proximal colon, versus being released at a pH of 1, such that it would be released in the stomach. So this is a space that I think is really, really interesting and may help us use some of these functional foods in a better way, in a safer way, such that we don't have a lot of systemic absorption, but we actually deliver it to the target tissue of interest. Other potential nutritional interventions, I'm hoping that others will talk about biotics. We know in chronic inflammatory enteropathy that this is a very hot topic, and we know that dysbiosis is a real problem for some of our dogs and cats. The causal link of dysbiosis and the pathogenesis of atopic dermatitis is a bit controversial. It's suspected, but certainly hasn't been proven. We do recognize that dysbiosis, especially during development, where there's a lot of changes that are happening to the microbiome, it's sort of like a very kind of shaky time, if you will. And so that's why things like stressors, early maternal separation, early infection, early antibiotic use could be particularly harmful in that space. We know that's a recognized risk factor for chronic inflammatory enteropathy, as Stefan mentioned. So there are several strategies that we could use to promote normobiosis: prebiotics, probiotics, postbiotics, FMT. I'll just briefly touch on prebiotics and postbiotics. Prebiotics are substrates that are selectively utilized by host microorganisms to confer a health benefit. And there's some recognized ones, including inulin, fructooligosaccharides, galacto-oligosaccharides. And these have numerous benefits, right? So they can enrich microbial communities. They can do some of the things that we talked about with polyphenolic compounds. They can actually provide a nutrient source to the intestinal epithelium so that the bacteria feed on the fiber rather than feeding on the mucus to help preserve that mucus layer. The effect, just like all of these things that we just talked about, is going to be dependent on the source, the dosage, the duration, the timing, the disease. So one study looking at a prebiotic fiber may show a benefit, whereas others don't, and that's just to be expected. It's a heterogeneous disease where sometimes there's going to be a benefit and sometimes there's not going to be. Postbiotics, this is a preparation of inanimate microorganisms or their components, so things like bacterial lysates, that confer a health benefit. In this figure, what you can see is these are children with atopic dermatitis that received an emollient and topical steroid therapy, and then were randomized to receive either a placebo or a daily oral administration of bacterial lysate from 11 different bacterial species. And this is sort of a disease severity index again, and so lower scores are better. And so what we can see is it did take a while. So it wasn't until 9 months, like we see with some of the other things that I've been mentioning. Sometimes nutrients take a while, especially if the disease has already been established. You may not see a benefit of something like a probiotic in chronic inflammatory space if you give it for 14 days and the disease has been there for a year. The same thing is true with postbiotics. Sometimes it's going to take time. So in this particular study, they didn't see any benefit until 9 months, but they did see a benefit. Why people are really interested in is in comparison to maybe something like a fecal microbial transplantation or probiotics. They could have the potential to be more stable, so have a better shelf life, and potentially have a higher safety margin. Microbial products have also been used to try to confer a benefit to the host. So I know we talked about butyrate a little bit yesterday in terms of, okay, could you just give a short-chain fatty acid and would that help? There are some studies, again, some show a benefit and some don't, with oral butyrate for humans with IBD. The problem, again, with butyrate, like we talked about with the carotenoids, like the polyphenolic compounds, is that you need to target the delivery. If you give oral butyrate without protecting it in some sort of a nanocarrier, it's going to be completely metabolized, degraded by the time it gets to the target tissue of interest. Botanicals receive a lot of interest as well. That would be something that I think really needs more exploration. There has been suggestion that they can have anti-inflammatory, antioxidant actions. There is a study looking at atopic dermatitis for dogs that received a botanical extract, and they did show some improvement in their pruritus scores when they received this extract. There is more information coming out about maybe the beneficial role of things like spirulina, berberine, but they, again, have variable bioavailability, efficacy, and so we need to test this more and get more clinical trials to look at efficacy and safety. One slide to talk about the beneficial role of amino acids. So Dr. Quimby talked yesterday about tryptophan and some of the harmful effects of tryptophan metabolism in terms of the kidneys. And then on the opposite end, tryptophan metabolites have a very beneficial effect on things like atopic dermatitis and chronic inflammatory enteropathy. So unfortunately, it's not a black and white issue for us, and that's why we talk about nutrition has to be individualized. What are all the different diseases that I'm treating? What are my nutrients of concern? If I highlight one nutrient, is it going to benefit one disease but actually cause harm to another? And so it's really difficult to talk about, well, when should we use things like taurine? Taurine, we know, is really helpful for keratinocyte hydration. So it could be really helpful for atopic dermatitis. Could it have a harmful effect somewhere else? We just don't know. So there's a lot of information about the beneficial effects of targeted amino acid therapy. Glutamine is certainly an interesting one in terms of it being a key substrate for enterocyte energy metabolism. Again, need to know more about what's the dose, how do we get it to the effective area. And lastly, I'm so glad that Jody talked about the role of stress Because I totally ignore it. When I'm, as a gastroenterologist, I do a really poor job of asking about stress at home, stress in the environment, what is the effect of stress. I can tell you, dogs with chronic enteropathy coming to me oftentimes receive Prozac, and I sort of just, I'm like, okay, yes, Prozac is one of those medications, and moving on. And I don't spend enough time thinking about, yeah, what is the effect of, what's going on? Why is your dog stressed? What can we do? Is there something that we can do in terms of the environmental modification? I was so impressed by Jessica Quimby's presentation of the case where she identified what the stressor was and handled it appropriately. And so that really motivates me as a clinician to think more about what is stress doing? How is the gut, brain, skin axis interacting with one another? If I can affect one, can I affect the other? We just heard about things like advanced glycation, in-products Maillard reactions. What is the effect of that on GI disease, on skin disease? We don't know. Emulsifier content, preservatives, microplastics, pollutions, detergents, household cleaners. We just don't know, unfortunately. And so I think that's something that with time, maybe with things like the Dog Aging Project, we will learn more and more about the role of some of those environmental exposures and what that does. And then diet variation. So our first presenter talked about diet, and variation of diet, especially in utero and early life, has a beneficial effect on immune-mediated diseases. We know that that is probably the case in our dogs and cats too, but we don't, to date, do anything about it. Like, at least I haven't done anything about trying to vary diet in early life for my patients, and so that's something that I think we really need to think about. So I'll conclude by saying the leaky gut and the leaky epidermal barrier plays a role in the development of disease, and these barriers are likely leaky for months to years before patients develop clinical signs. We need to think about that. We need to recognize it early or think that that's probably there. That patient with acute hemorrhagic diarrhea syndrome probably has a leaky gut. Should we go ahead and intervene now? Should we feed a diet that's enriched with spirulina? Should we feed a diet that's enriched with colostrum now to have a beneficial effect later in life? We should be proactive and not reactive. And then a multimodal modification of nutritional environmental factors is not going to work. Some dogs have dysbiosis. Some dogs have inflammation. Some dogs have a decreased mucus layer. Some dogs have loss of water in their skin. Some don't. And so the one-size-fits-all approach won't work. We have to think about each of these patients individually. So I do want to thank you for coming and for the Purina Institute for having me. This has been an amazing conference, and I've learned so much, so I really appreciate it. And I'll take time for, if there's time, for questions.